we are live now. Hello.
Yes.
Yes, sir, we are live now.
Okay.
Yeah.
Should I start?
Yes, sir, you can start.
Good evening, friends. This is Dr. Quresh Maskati, an eye surgeon, telling you something a little funny when you should not be referring patients to me. There is a reason for this, but first a little bit about myself. I am an eye surgeon passed out from KEM Hospital approximately 1 million years ago. And I have been president of Bombay Ophthalmic Society, Maharashtra Ophthalmic Society, All India Ophthalmological Association, president of Cornea Society of India, Cataract and Refractive Society, and so on. I won't bore you with more details. I've written some chapters in books, presented at various conferences, and I've written a book for the common man called Simplifying Eye Care, which is available with me at rupees 200 each with free postage. Anyone who wants it it's in a question-answer format, explaining to the common person about various eye diseases like cataract, glaucoma, etc. Without further ado, let me share my screen. So what are the conditions, common eye conditions in the eye where no referral is required? Let us so first is conjunctivitis in the newborn. So let's start with a child who's just born. So if you look at the eye, look at the child's eye, and you see that the cornea is not affected. See that black portion in the middle? That's the transparent part above the iris. That's the cornea. So you confirm that the cornea is not affected. There's no corneal ulcer. If you can do that, you simply explain to the parents. They're very anxious because they got discharge from the eye, redness in the eye, and it's a newborn child. Just explain about hygiene, how to clean. Nowadays, you get sterile wipes available on Amazon and in any chemist shop, which just contains small cloths, sterile cloths with some liquid. Some of them have antibiotics, some of them are just distilled water. So they can clean the eye with that or with some tissue from outside. Explain about broad spectrum antibiotic eye drops. We put frequently, at least 4 to 6 times a day. You could use the 4th generation fluoroquinolones like gatifloxacin or moxifloxacin eye drops. And usually this clears up in about 4 to 5 days. It's usually because of infection in the vaginal passages, and it usually occurs after a vaginal delivery, very rare after a cesarean section. Let's move on. The child is now a little older, and the parents come to you saying that, you know, the child was fine for the first 2-3 weeks. And after the child was a month old, he started watering from one eye or both eyes. This is again quite common. It's usually due to non-canalization of the nasolacrimal passage, the passage which goes from the eye to the nose. And that's supposed to canalize in the 9th month of intrauterine life. But sometimes the timing goes a little awry, and that passage, which should be with a lumen, is still plugged with some epithelial cells and debris. So there's no place for the water to flow out of the eye. That's why the eye waters. Why does it not water at birth or after a month? Why after a month? It's simply because our child produces very little tears in the first 1 month. So therefore, there is no overflow of tears. It's only after a month or so that the tears are similar to the adult tears. So what is the treatment? Do you refer it to an ophthalmologist? No. You tell them that this is a self-limiting condition. It will canalize usually within the first 12 months after birth. Of course, we don't wait that long. So you prescribe massage over the lacrimal area. So if you can see this over here in this area, ask them to massage, see that the fingernails are cut short, otherwise they will cause abrasions of the skin, and massage quite firmly in this, it's sorry, wrong area. This is the nose. So in this area, you ask them to massage. So this is the passage which is blocked. So when you massage, the epithelial plugs come out and the thing canalizes. Should we be putting antibiotic drops? The topical antibiotics can be used if there is a sticky discharge. If it's just water coming, then there's no infection. We don't need to load the patient with antibiotics. Just a simple massage in this area will be fine. And if there is no improvement for 9 months, if sometimes the patient may come at 1 month, he may come at 3 months or at 6 months, give a choice of at least 1 month to 2 months of massage. If it is improving, ask them to continue the massage. If it's not improving in 2 months at all, with zero improvement, or the child has crossed the magic figure of 9 months of age, only then you refer to the eye surgeon. What will the eye surgeon do? Will confirm that they were massaging correctly. And if he finds that there is no improvement, he will order or he will do a probing. Probing is nothing except just like a plumber uses a metal probe to probe a basin which is choked. Similarly, we use a silver probe. We pass it through the puncti, which is the upper and lower lid of 2 puncti. So we pass the probe through the punctum and open up the canal. So it's an external approach. It takes 5 minutes under general anesthesia. But we wait normally. Why do I say 9 months? Because by the time I tell them it's under GA, oh my God, you're going to give GA to such a small child and so on. It takes them a month and a half to consult their grandparents, the relatives on the mother's side, father's side, 27 people decide. And they come to me when I start telling them in 9th month, they come to me by the 11th month. So the prognosis is best, more than 95% success if done within the first year. If you wait for 18 months or 2 years, the prognosis drops to 80% and less. Then the child is growing up and the parents come to you saying that there is this silvery white appearance. Sometimes there is pigment in it, sometimes not, on either side of the black portion of the eye. So these are known as Bitot spots, which are due to vitamin A deficiency. They require no surgery, no excision, and they disappear like magic with intramuscular and oral vitamin A supplements. If the community has got this, if you see a lot of it in the community and you're a family practitioner in a slum area, you may do a community giving of vitamin A, which is extremely cheap and fairly easily available. So again, these are harmless conditions requiring no referral. What about refractive errors in children? The child has been given minus powered glasses by the ophthalmologist and the parents are extremely worried. They try to ask the eye surgeon some questions. The eye surgeon shoos them away. He's given glasses. His work is over. He's taken his consulting fees. So they come to you, the family physician, the general practitioner, and ask, what is this, doctor? And they ask all types of questions because the ophthalmologist has no time or inclination for counseling. So this is where you come in. So if there is a refractive error called myopia or short-sightedness, where they have to wear concave glasses, you explain to them that their eyes are not weak, that the child's eyes are extra powerful. Why do we say extra powerful? Because they bend the rays of light so much that they focus in front of the retina, as you can see in the middle picture. So we are giving them weakening glasses so that the rays of light focus on the retina. So first you tell them that the child's eyes are extra powerful, they feel good. Then explain correct visual hygiene. What do we mean by that? Except for school work where they need to use the mobile phone or an iPad or a laptop, tell them that for recreation, they should not be using it, no video games and things like that. Less of near work, more of outdoor activity. It's been now conclusively proved that if a child spends more than 2 hours in play outdoors in the sun, the chances of the number progressing drop by 50%. So that's what is meant by correct visual hygiene. Explain that no matter what we do, sometimes the minus number can progress with age, but there is no problem. as the child grows older, they won't have to wear thick glasses. We can give them contact lenses. And when the child is above 18 years of age and the number is not progressing, about 80% they stop progressing by 18. The eye surgeon can always do a LASIK surgery to remove the number very, very safely and effectively. So counsel them on myopia. I told you about importance of reducing screen time, importance of spending at least 2 hours a day outdoors. And there is a newer treatment regime. If the eye surgeon has not explained it, you tell them to go back to the eye surgeon and ask them about 0.01% atropine eye drops. This is the normal atropine is 1%. This is 0.01%, which doesn't cause pupillary dilatation. But one drop in both the eyes at night can halt progress in about 70 to 80% of myopic children. This technology is now quite tested. It's a very simple thing, just one drop at night. They can put it till the child is 16 years of age, daily at night. And in 70 to 80% of cases, it can halt progress. Then they will, when you talk to them about LASIK, they will ask you, is my child a suitable candidate? Is it safe? So you say it is already safe. Your child is 5 years old now. And there are different ways. There is PRK, LASIK. There is also femtosecond and SMILE and things like that. Throw these big words at them to show them that you know as much as the ophthalmologist. But tell them that you can't do it because the US FDA says you should not do it till you're 18. Because if the number progresses, you cannot repeat this LASIK treatment. So tell them that when the child is 18, you will tell them more about it. What about a child who has plus number? That's called hypermetropia. So they have to wear plus numbered glasses or what is called convex glasses. So you explain to them that again, parents are worried these are thick glasses. So again, so don't tell them the eyes are weak. Explain to them that the child's plus number will not increase. In fact, it may come down as the child grows older because the eyeball expands. The rays of light, as you see in the top picture, in a hypermetrop are focusing behind the retina. So as the child eye grows, as the child grows older, they will then focus on the retina. So in almost all cases, hypermetropia may remain stable or it may reduce with time. The plus number may remain the same or go down with time. The third refractive error is astigmatism or cylindrical number. So explain to them because the eye surgeon has had no time to explain. Tell them what is meant by cylindrical number. It's only a focusing number. So it usually remains constant. It's because of the shape of the cornea. Instead of the shape being cylinder, what you call spherical, it is like a cylinder. So that it usually remains constant. Tell them that just like the shape of the nose doesn't change, the child can see everything, but it's a little defocused or unfocused, like you see that clock picture down there. So that is astigmatism, and it will remain the same. It will not increase with age. Then the child grows older and might injure himself, and you get this red thing over there, blood clot over there, and they are very worried and they want to rush to the ophthalmologist. Tell them no need, because this is a subconjunctival hemorrhage, the hemorrhage under the conjunctiva. This blood clot will disappear in about 10 to 15 days. Tell them it will turn from red, bright red, to orange, yellow, and then disappear. So they will be saying how wonderful your knowledge is because it will behave exactly like that. And tell them they don't need to put any drops, and they should inform the friends of the child not to worry. Otherwise, the school teacher will also tell them, go back, there is some infection. So there is no infection. This is a harmless subconjunctival hemorrhage. Usually can be due to blunt trauma. In older patients, it can be just because of little fragility of conjunctival vessels. Needs no treatment, no eye drops. If they are very worried, you can put some tear drops like a placebo. Then this picture, the other picture that you can see, those two pictures, these are conjunctival nevi. Conjunctival nevus, or it's like a birthmark which somebody can get anywhere on the skin. You can get in the conjunctiva also. So what you do nowadays, you have these smartphones. Don't refer the patient, just take a picture and tell them, come and see me every 6 months, and be sure you charge them every 6 months. So then you can take a picture and prove to them that this nevus is not expanding, it is not increasing. And till I tell you, don't go to an eye surgeon, because otherwise he will do unnecessary surgery. Of course, if it is cosmetically very disfiguring and the parents want it, that's a different thing. but otherwise the nevi can just be kept under observation. Some patients, young adults, have prominent conjunctival blood vessels like this. There is no bimari, there is no disease as such, but the blood vessels are a little prominent. Sometimes this is because of dryness in the eye. So you can treat these with simple tear drops. And if the patient is not symptomatic, then you can tell them to just leave it alone. If they want to go for a social occasion and people think they are drunk or something, then you can give vasoconstrictor drops which contain nafazoline, so that in about half an hour it will become white and stay white for about 2 to 3 hours. Not to make it a habit, but they can use it as and when required. Some other harmless conditions are little blobs of fat that they see on the white of the eye. These are called Pinguus or Pingueculum. So you can see them in the pictures over here. Again, if you like, you can take pictures of these and you can leave it alone. It is not always associated with high cholesterol or anything like that. If you're getting a cut from a pathology laboratory, you can get a serum lipid profile, but it's not really required. They're harmless, can be left alone. About 2% or 3% of them grow into pterygium, which encroaches over the cornea, and that needs treatment. But as long as it is a pingueculum and not encroaching on the cornea, no treatment is required. As I told you, some of these grow into this degenerative condition called pterygium. So it's encroaching on the cornea. So again, do all pterygium require referral? No. If you see the pictures on the top, these are atrophic. They are not disturbing the patient. If the patient is adult and already married and his spouse accepts this condition, then you don't have to do anything. Again, you can tell them that if it worsens, we can always refer it. Because what will happen is when you refer it to an eye surgeon, they are usually knife happy. They will operate them. 10% of these pterygia will come back with recurrence. And when they come back with recurrence, if you see the lower picture, the recurrence is so much more fleshy and looking worse than the atrophic pterygium which was there. So when do we remove a pterygium? If the patient is a contact lens wearer and can't wear the contact lens because of the bump, if the patient is in an industry where he has constant exposure to the public, like a film actor or a television actor or something like that, then it's cosmetically disfiguring. If the patient is a narcissist, means in love with themselves and don't like this look, then we need to refer. And if the pterygium is growing and is encroaching onto the pupillary area, then the vision can go down. Only in these 4 cases do we need to refer it to the eye surgeon. The rest you can manage by just reassuring them and asking them to put some tear drops in the eye again, because there is a greater surface area from which tears can dry up, and the patients often have little dryness in the eye. So observance, maybe mild vasoconstrictors, surgery only if there is a cosmetic blemish, as I told you, or if it's producing a high cylindrical number, only then. And if you're referring them for surgery, tell them no matter how wonderful a prognosis the eye surgeon gives you, there will be a 5 to 10% chance of recurrence. Then there is acute conjunctivitis, where the eye looks like this, lot of discharge. This is the middle one is an extreme case, lot of discharge, redness. But usually it's like the gentleman whose face you're seeing on the top, where both eyes are mildly red. There may be watery and a little sticky discharge. These are usually viral. The one in the middle, the large picture, is bacterial with that amount of puck which you can see. But most of them are viral. All the others that you see are viral. And these can be treated with just cold compresses so the patient feels better. Just take a handkerchief, put it in the refrigerator or put ice in a handkerchief and apply it over the closed eyes. The patient feels symptomatic relief. You can give the patient tear drops so that all the discharge which is there is washed away. Every hour, every 2 hours, you can put some tear drops. And if you must give antibiotic drops, give something like chloramphenicol or a mild antibiotic, because these are viral in most cases. And whatever you do, whether you give antibiotic or not, is going to subside in a week's time. Important thing is that they are infectious for the first couple of days. So make sure that they use tissues to dab their eyes and throw away those tissues. And if it's a child, don't send the child to school for 2 days till you started the antibiotic drops, and then you can send the child to school with a note saying the redness will take 8 days, but the child is not infectious to anyone. So again, in acute conjunctivitis, by and large, viral or bacterial, you don't have to refer it to the eye surgeon. There is a different type of conjunctivitis called allergic conjunctivitis, which you will see in children, where predominantly there's a lot of itching. You can see the picture there of the child trying to close the eye and itching. And if you look closely, then around the limbus, around where the black and the white meet, you get bumps over there. That's called the bulbar variety of allergic conjunctivitis. Bulbar means on the eye. And the other type, if you evert the lid, you see a cobblestone-like appearance. That's called the palpebral type of allergic conjunctivitis, because palpebral means eyelid. And this is because of destabilization of mast cells. That's an artist's picture of mast cells from which the eosinophilic granules are liberated, and they cause the allergy. So the treatment of allergic conjunctivitis is basic hygiene again. Tell them no rubbing of the eyes. Cold compresses will help. In mild cases, you can give non-steroidal anti-inflammatory drops topically. There are mast cells inhibitors and dual action drops, which are mast cell inhibitors and non-steroidal NSAIDs. So we use steroids very sparingly. If with all the above 5, it doesn't come under control, only then you should refer it to an eye surgeon who will possibly start steroids and give them as pulse therapy. Remember that steroids can cause dryness of the eye and glaucoma and cataract. So better the eye surgeon gets blamed for it rather than you, because many times the patients become addicted to the steroid drops. Let's move on to foreign bodies on the ocular surface. So if a patient comes to you complaining of foreign body sensation, don't rush to send him to the eye surgeon. Evert the upper lid. Sometimes look for the foreign body. It is stuck under the upper lid. If it's a conjunctival foreign body which is under when you evert, you see it. You can remove it with a cotton bud itself. You can put a drop of 4% lignocaine or proparacaine drops, but throw away the bottle after that. Don't give the bottle to the patient, because it gives you local anesthesia. Patient will never get foreign body sensation, so they will love you and they will continue to use the drops and cause complications. Only if the foreign body is on the cornea, as you can see in the pictures, all the 3 pictures, then it is better to refer the patient, because the eye surgeon will have to scrape it out and he will abrade the cornea. He might have to put a patch on the eye at that time, and then he may or may not put antibiotics. So if it's a foreign body on the cornea, it's better to refer. But if it's a conjunctival foreign body, you can remove it yourself. Youngsters will come to you telling you that they're complaining of foreign body sensation or sandiness or grittiness or even occasional watering. There may be no redness. Typically, the symptoms worsen in the evening after 8 to 10 hours on the computer, and the symptoms are less on holidays. So you have already diagnosed that this is a dry eye because of what is called computer vision syndrome. That is, whenever the patient is looking at the computer screen, his blink action is less. You see that picture of the blink? You're supposed to blink 30 to 35 times a minute. But a person who's on the screen for 10 hours a day, his blink goes to 15 times a minute, because subconsciously he is worried about losing data which is on the screen. So he blinks less, so the eye remains open and the tears evaporate. So you can treat with over-the-counter lubricants, tear drops of all types. There are about 100, 150 different brands. So teach them the importance of taking breaks. Every 30 minutes, take a break for about half a minute. Teach them the importance of blinking consciously while on the screen. And if the patient is better with all this treatment, gradually they can stop the lubricants, eye drops as well. So again, no need to refer the patient. Sometimes the dryness goes hand in hand with some like a dandruff of the eyelashes. If that happens, again, you can treat. If there is dandruff of the scalp, you can treat that as well. Sometimes you get this dandruff of the eyelashes without scalp dandruff. So you can just treat with proper cleaning of the eyelids with a mild detergent soaps. Continue the treatment for 4 months. Tell them to continue. Usually it recurs. So if it recurs and patient comes back and tells you he was better, but it's come back, you tell them you didn't clean for 4 months, as I told you. Since no human being has been known to clean for 4 months at a stretch, because it's very boring. you can have the upper hand and the patient says sorry to you and continues paying fees. And you can give a mild broad spectrum antibiotic ointment to the lid margin, not into the eye, just at the margin. If the patient comes to you with a serious condition like this, a corneal ulcer, then also there is a role of the family physician before you send the patient. So use a torch to examine the eye. If necessary, use magnification like a loupe. Look for foreign body corneal abrasions. Invert the eyelid in every case. If the patient is wearing a contact lens, ask the patient to remove the contact lens immediately. Don't give any steroids because it will make the patient feel better, but the ulcer will become worse. It will alter the infective pattern. So simple ulcer might become a fungus, which is difficult to treat. So no steroids to be put, just simply, and no pad to be applied. Why? Because when you apply a pad like that, the heat inside increases, and heat is good for all the germs. So don't apply a pad. Just you can put some, open the eye, you can put some frequent antibiotic drops if you like, and simply refer the patient. So what drops can you start? If you can get atropine drops, every ulcer will benefit by atropine drops. Lubricant drops, you're washing away the germs from the eye, so you can't go wrong with that. And you can use broad spectrum antibiotic drops such as fluoroquinolones and refer. See to it that within the first 24 hours, the patient is referred in these cases. It is important. We won't go into the details of why the referrals, because the eye surgeon can do a lot of lab tests to find out bacteria, fungus. We have instruments like the slit lamp that you're seeing below. So we can do a better job. But before you send the patient, clean the eye, put atropine, start the patient on lubricants, and then refer. What about cataracts? I'll just end with this. Patients will come to you, when should I have my cataract operated? If he has asked the same question to the eye surgeon will say tomorrow morning, otherwise it will be too late. What should you be saying? You should say that whenever it causes you a visual handicap such that you're unable to do what you could do. So if you're a golfer and you find you can't play golf well, get it operated. If you're a taxi driver and you find that you can't earn your rosy roti, you can't drive at night, headlights bother you, get it operated. So whatever you are used to doing and you can't do, then only go to the eye surgeon. Otherwise, he will needlessly operate a cataract just because it is there. Mount Everest is there. You and I don't climb it. No, leave it to the climbers. I'll just end with some other conditions where no treatment is available at present, neither by you nor by me. Night blindness or retinitis pigmentosa. Persistent vitreous floaters. If the eye surgeon has ruled out retinal problems, they have to be left alone. Optic atrophy where the nerve of the eye is dead. Patient with no perception of light, no one can do anything. So family physician should counsel such patients to avoid doctor shopping. Don't let them go from eye doctor to eye doctor. Sooner or later, they will come to an unscrupulous eye doctor who will charge them lakhs of rupees and give some nonsensical treatment. Thank you so much for your attention. This has been me since the past 30 minutes talking away. I am aware that some of you have gone to sleep, but I'll end my talk here and I'll be happy to answer the questions which have come in the chat box. I'll stop my share now. Thank you so much.
Yeah, thank you. Thank you, sir. I will be sharing the questions now. Yeah.
Yes.
Yeah, sir. The first question is, should any lifestyle changes to prevent eye disease and disorders?
Yes, that's a very good question. A lot of lifestyle changes. Let's start again, as I said, with age. If it's a school-going child, they must reduce their dependence on gadgets in the house. The smaller the gadget, the worse it is. Mobile phones are the worst. Large screen TVs are a little better, and everything in between. They must spend at least 2 hours a day outdoors in outdoor activity, games, and things like that. If you're older and in a job, computers, every 30 minutes, take a break for 30 seconds and blink more often. After the age of 40, you must have an annual eye checkup because the glaucoma can only be detected by the eye surgeon. So also cataract and dry eye can be detected by them. if you're a diabetic, even if you have no visual symptoms, you must see an eye doctor once your diabetes is detected, and he will then decide how often you should come, usually once a year. If there are changes of diabetes in the retina, then he may call you more often, because he can do a laser treatment for you before it is too late. So he can actually prevent blindness. If you're above the age of 60 or so, you might get age-related macular degeneration. Again, an annual visit, and we can help such patients as well. Thank you.
The next question is, what new signs or symptoms should I pay attention to?
Okay, so the most dreaded problem in ophthalmology is what is called retinal detachment. If you're a minus numbered person or a myope, you have 3 to 5 times the chances of developing retinal detachment in your lifetime than somebody who doesn't have minus numbers. So there are 3 symptoms you should see. One is persistent flashes of light, not an occasional flash of light, but persistent flashes of light. You see one now, you see one after 10 minutes, then you see another after 5 minutes, you see another after 2 minutes, it keeps coming. Second is rapid increase in floaters. You may see 2 floaters today and 4 floaters tomorrow. That's not a rapid increase. You see 10 floaters just now, and 5 minutes later you see 100 floaters, and 2 minutes later you see 1,000 floaters. That is what I mean by rapid increase in floaters. And the third is a sudden drop in vision, either peripheral vision on the side or straight ahead vision. These are the 3 signs that there is an impending retinal detachment. Within the next few hours, you should see an eye surgeon who will dilate your pupil, confirm this, and schedule an early treatment surgery for you, maybe just a laser or a full-fledged surgery, depending on the condition of the retina. And you could get almost 100% chance of getting your vision back. Thank you.
Last question now. Which conditions are included in the differential diagnosis of plateau iris glaucoma?
I think this is too technical a question for this audience. There are different types of glaucoma. One of them is a plateau iris, which can't be mistaken for anything else. When we do an investigation called gonioscopy using a gonioscope, or we can do an ultrasound biomicroscopy, and we can diagnose this very easily and treat it as required. Thank you.
Yeah. Thank you, sir. We are done with all the questions now. And thank you, sir, for your valuable time and sharing important insights on the topic.
My pleasure.